Can we start?
Yes, ma'am.
Okay, fine. So this 65-year-old gentleman who's about 100 kgs in weight, appears to be quite obese, who's a known diabetic, came with features of acute intestinal obstruction. So he underwent an emergency laparotomy at in your hospital, and you found a gangrenous segment of gut, which you resected, and you have brought it out in the form of a stoma. Okay, so intraoperatively, there weren't any issues, but postoperatively, around day 3 or 4, when you were doing the first check dressing, you saw that there was some discharge in his dressing. Are you clear about the history? 65-year-old gentleman, 100 kgs weight, obese patient, known diabetic, came with intestinal obstruction, underwent emergency laparotomy in your hospital. There was a segment of gangrenous gut, and you did an excision and brought it out in the form of a stoma. Intraoperative events were uneventful. And on the day 3, when you were doing the first check dressing, you found some discharge in the dressing. So what is your impression of the patient? What is the impression of the scenario? Regarding the dressing and the wound check that you did, that is what I want to know. What is your impression?
First, I will this could be the first I will check the wounds, ma'am, whether the discharge is serous, serosanguinous, or pus discharge, or fecal discharge, anything else.
Okay, I'll just stop you. I'll take it one at a time. You gave me 4 options. You said it could be serous, it could be serosanguinous, it could be pus, it could be fecal, right? You said there were 4 scenarios. Now, if it was a serous or a serosanguinous discharge, what would be the significance? Would you be very worried if it was a serous or a serosanguinous discharge? Would you be very worried if it was a serous or a serosanguinous discharge?
Check the amount of discharge, ma'am.
And my point is, if you've checked the dressing and you press the wound and you see that it is a serous discharge, are you very worried? Is the serous or a serous? Not so, exactly. That is the one point I wanted to hear. A sero or a serosanguinous discharge is not a major cause of concern. Now, if you have a pus discharge, what is your impression? If you have a pus discharge, yes.
Then it could be surgical site infection.
So there could be a wound infection. Okay. Yes. If there was a fecal discharge, you gave a 4th scenario where there could be a fecal discharge. If there is a fecal discharge, what is your inference?
There could be the leak from the site of stoma.
Yes, you've done a stoma. Yes, agreed. In this case, there is no anastomosis. If there was anastomosis, you would have been a very worried man. But even in case of a stoma, I mean, I would have asked more questions. I mean, is the stoma functioning? Is there one end of the stoma which has, sunk in or retracted? Or were there other injuries in the gut or devitalized segments of the gut which might have given way? You had discovered one gangrenous segment. Were there other gangrenous segments which you missed intraoperatively? So that would again be a cause of worry. But the point to be highlighted is that a discharge of pus is an evidence of wound infection, but a discharge of serous or serosanguinous is not so much an evidence of wound infection. That is the take-home message. Fair enough. So you use the word wound infection. What do you understand? Yes. How would you, if I asked you to define wound infection, how would you define wound infection?
There is invasion of the microorganism.
Yes. Yes, please continue. You're right.
form of inflammation,
See, if there is
cellulitis, lymphangitis, or
so if there is cellulitis or lymphangitis, would it be a wound infection? What is the most important factor which has to be satisfied for it to be a wound infection? I would request Ganesh and Nitish to keep their mics on because Omkar's bandwidth seems to be poor. So if we lose him in between, you people please come in with the answers. Otherwise, the discussion will not move. Ganesh, Nitish, yeah, Ganesh, till Omkar comes back, try to please fill in for him. I asked him that what by definition is a wound infection. He was going on the right way, but we lost him in between.
Wound infection definition.
Yeah, what by concept is a wound infection? He very correctly said a serous and a pseudosanguinous will not be considered a wound infection. So to clarify our patient to be having wound infection, what are the factors that it must satisfy?
Sorry, I don't know.
Okay, so the point is that number one, it is not just inflammation. Inflammation is not equal to wound infection. Okay, so there must be microorganisms within the wound and they must be replicating microorganisms. So if you have the presence of replicating microorganisms within the wound leading to tissue injury, that is what is by definition a wound infection. Omkar is back. So I repeat the definition for you, Omkar. The presence of replicating microorganisms in a wound leading to host tissue injury, that is by definition a wound infection. Clear? Okay, fine. So our patient, we said that, you said that there could be some pus discharge.
Sorry, ma'am. Yes, ma'am.
Yeah, sorry, yes.
Yes. Yes, ma'am.
Can you hear me?
Yes, ma'am.
Okay, fine. So our patient, when a patient comes to you or patient is in the ward, what are the characteristics when you take your rounds in the ward, which will make you suspect a wound infection?
First, I will clinically assess the patient.
Right. And what are the things you will look for?
Yes, ma'am. First, I will ask the history, do proper clinical examination, assess all the charts, and then proceed accordingly.
No, what I want to know is when you are clinically examining your patient during your morning rounds, what are the clinical findings which will make you suspect that yes, this patient has wound infection?
Yes, ma'am. First, patient will have tachycardia. There will be a raised temperature, signs of inflammation. There could be toxic look. There could be the pus discharge from the wound. And total leukocyte count will be raised. And neutrophilic count will also be raised.
Anything else?
CRP will be raised.
Before sending your investigations, when you're looking clinically, anything else? So let's divide it into three headings: local findings, systemic findings, and lab findings. Okay. So local findings will be what? Number one, that area may be hot or warm. So raised local temperature. There may be induration in the area, features of inflammation. There may be redness. There may be edema. Pus, what you had correctly said, there may be discharge of pus. Systemic features, there may be pain, fever, and sometimes the wound may give way. You might have a wound dehiscence. And lab features, as you very correctly said, the count may be raised, the CRP may be raised. But remember, just a local infection may not always give systemic features like pain and fever, may not always give a raised leukocyte count. So first concentrate on the local findings. You will have a local rise of temperature, local induration. There may be some erythema, there may be some swelling or edema, there may be some discharge of pus, and As far as the systemic findings are concerned, there may be fever and pain. And as far as the lab findings are concerned, there may be leukocytosis and raised CRP. Okay. So always divide it into 3 segments: local findings, systemic findings, and lab findings. Now, our patient, what do you think were the factors which contributed to the wound infection? Our patient.
Yes.
You remember our patient profile, don't you?
Yes.
Yeah.
First of all, the host factor. Patient is immunocompromised. Patient is diabetic, obese.
Yes.
And, then there could be the surgical technique, how suturing has been done, whether suturing suture is tension is in tension,
Okay.
abdomen closed in layers is in tension or normal, and then then instrument, whether instrument is whether it is properly sterilized or not. Environment, theater environment, airflow of the OT, whether it has
so
laminar
theater sterility, yes. What else?
And immunity of whether host response in the form of cell mediated immunity or humoral immunity.
Are you there, or is it just your video which has gone off? Are you back, Onkar? Yes, are you back?
Yes.
Okay, fine. So let's again, you were very correct to begin with. You can broadly divide it into 2 headings again: patient factors and procedure related. I think you can keep your video off. That way, at least we can hear you better. So you can have it as patient factors and procedure related factors. So, and when it comes to patient factors, yes, you were correct. It could be age. There was obesity. There was diabetes. What could be the other patient related factors? Not in our patient. Other patient related factors which we have to keep in mind?
Yes. Other comorbidities like history of TB, CLD, chronic liver disease, smoking, immunocompromised.
Very good. So other features of immunosuppression, any immunosuppression, whether it is HIV, whether it is following COX therapy. So you have age, you could have malnutrition. Obesity is a form of malnutrition, isn't it? The other extreme of the spectrum. There could be steroid intake, history of steroid intake for any reason. There could be diabetes, there could be immunosuppression, history of smoking, or any other coexisting infection. If you notice that when we do a hernia surgery, very often we also do a urine test. The whole idea of doing it is what? That if there is an UTI, we would like to get it, yes, we would like to get it treated before we put an implant meaning the mesh, because we don't want a coexisting infection which might lead to infection of our mesh. So any other coexisting infection. As far as the procedure related, what could be the surgery related? One, again, procedure related could be surgery proper related or theater related. You very correctly said that, theater sterility, surgeon related sterility, whether we are washing our hands properly or not, whether the instruments are sterilized properly, whether the gown and the gloves that we are using are sterilized properly. But what could be the surgery related issues which could lead to more wound infection?
Sir, technique of repair.
Okay, so what about the technique?
Whether there is intraoperatively there is a bowel injury or not.
So you mean to say that you're converting a clean surgery to a clean contaminated surgery? Is that what you're saying? But even a clean surgery can also have wound infection, isn't it?
technique of repair, abdominal repair, abdominal layer repair, whether it is in tension, closed in tension or not.
Okay. So if there is,
type
if
of
it
suture
is,
material used,
what type of
for
suture material will lead to more infection?
Silk, if closed, if ma'am, um,
See, the idea is that initially, you know, we used to say that it is polyfilament sutures, you know, that theoretically there is a possibility of harboring of organisms within the polyfilaments. But now they are, I mean, it does not hold true anymore because they are all pre-sterilized packs which are opened in front of you. If you are using polygalactic acid, that's a Vicryl, they will open a pre-sterilized packs. So that those chances have gone down. So not so much of the suture, but what we are looking at is, you know, if there is a hematoma, if there is a collection within the abdomen, if there is, suppose there is a perforation and you have not given a thorough wash or you have not sucked out all the fluid intra-abdominally, these are the patients who have a higher chance of developing a post-op wound infection. If there is a hematoma, that might secondarily get infected to give you wound infection. If there is a lot of dead space, you have some patients who are very, particularly in obese patients, who has a very thick abdominal wall. So you have closed the sheath and you've closed the skin. There's a big space in between. That is the area which has a potential to give you a lot of wound infection. If there is a prior wound infection, prior some skin infections, there also there is a possibility of wound infection. Pre-operatively, is there any role of shaving? What has the principles changed? Like when we were students, we were always told that pre-operatively you should shave. What is the potential risk of a pre-operative shaving of the patient when it comes to wound infection?
No, it is the recommendation that shaving should be done on table by clipping. If it is done pre-operatively at night or by using shaving, then there could be minor cuts on the skin which could lead to the infection, increase the risk of infection.
Okay, so the thing is that try to avoid it as much as possible unless it is absolutely mandatory. Routinely, there should not be any intervention at all. If at all required, if it is a very hairy area and you are going to plan your incision to that area, do not think of shaving, just use clipping or one of these epilatory creams, because these micro wounds that you create, the abrasions that you create, they might get secondarily infected at a later time to give rise to wound infection. So pre-op shaving is categorically off from the principles. What about skin preparation? Is there any role of how you prepare the skin to avoid the wound infections?
Yes, ma'am. First of all, if a patient take bath by povidone ointment, then it decreases the chance of infection. And during operation, if we if we wash the area with the povidone iodine, then it also decreases the chance of infection.
So the basic principle is prior to surgery, the patient should be encouraged to have a thorough bath with soap and water. And on table, it should be scrubbed generously with a antiseptic scrub, followed by painting with an antiseptic solution. Okay, the scrub should not be the last step because the scrub has soap material in it, which we do not want to leave on the skin prior to the incision. So first it should be scrubbed, followed by cleaning of the scrub, and the last step should be a solution. There are some schools of thought who believe in putting a coat of alcohol or a spirit over the skin, but that is again debatable because others feel that there might be some flames when you use the diathermy if you're using the initial skin incision using a diathermy. So there is a debate regarding that, but the point to be noted is that the scrub should not be the last step. It has to be cleaned, and a coat of povidone iodine solution should, or any antiseptic solution has to be applied. Now, you said that all of these factors, be it patient-related factors or procedure-related factors, may lead to the formation of an SSI. So what is the first step? Why does suddenly SSI happen? It doesn't happen in all your patients. So what is the first step in the pathophysiology of the SSI?
When we are operating on the patient, we handle this tissues. This leads to the activation of cytokines and release of interleukin 1, 6, 10.
You are talking about inflammatory markers. We said that by definition, a wound infection means there is presence of replicating microorganisms, right? It
Yes.
may be associated with inflammatory markers. So my point was, how does it initiate? What is the first step? Those replicating microorganisms have to be present in the wound in some to begin the process. So
Yes.
the first step is always a microbial contamination of the surgical wound, right? The the microbes have to be present in the wound. Now the next question, obvious question will be, where do the microbes come from? How
Yes,
do the
ma'am.
microbes reach the wound? You have been so cautious. You've cleaned the wound. You've given the patient a bath. You've given a course of antibiotics, prophylactic antibiotics, but still there are microbes in the wound. So how do the microbes reach the wound?
Mostly it is due to the endogenous organism.
Okay. So where do the endogenous organisms come from?
Mostly present in the large intestine, ma'am.
Large
which,
intestine. Okay. Let's assume I've done a hernia surgery. I've not gone anywhere near the large intestine. Even a hernia patient may have wound infection.
yes,
So where did it come from? Yes, large intestine or any hollow viscera for that moment may be a source of endogenous microbes. So, but what else? What other possibilities more common?
yes, ma'am. There could be the other exogenous factors, ma'am.
No, in endogenous. I'm still at endogenous. I'm still at endogenous. Think from the surface. Yes, think from the surface and then go deep.
Yes, ma'am.
Think from the surface and then go deep. You started from deep. So think from the surface.
Yes, ma'am. Endogenous organism like staph epidermidis.
So as you said, epidermidis. So where does it come from? From the epidermis. So that's from the skin, right? So you can have flora from the skin. You can have flora from the mucous membrane. And yes, you can have flora from the deeper organs, gut being a very common source. So when you have organs, when you have this endogenous microorganisms, do not always think that it has to be from the deeper organs. The commonest source is actually the skin. And that is where the role of a very good pre-op preparation of the skin, the scrubbing and the painting is important, so that you minimize the endogenous flora, which might lead to a post-op wound infection. What about the exogenous? You said that there were some exogenous sources of microbial contamination.
Yes, ma'am. Nosocomial infection through the healthcare workers.
So nosocomial, when you say, that means it's a hospital acquired infection. So, okay, so it could be from the healthcare workers. That means you are the surgeon, you have not washed your hand well. So that could be a source of. What else? What else? You had actually touched upon
environment. OT instrument.
You had actually touched upon it sometime back.
Yes,
OT sterility. Absolutely. OT sterility. OT instruments. Whether the OT instruments have been sterilized well, whether, if you remember the WHO checklist, there is a very important point that has sister checked whether the instruments were sterilized adequately. That is very there. You had talked about laminar airflow some time back. Yes, it is true that every OT does not have laminar airflow, but whether the OT floor, wall, table, everything, even under the table for that matter, has been sterilized adequately. So it could be from the OT, it could be from the instruments, it could be from the personnel. Personnel meaning not just the doctors, it could be the nursing staff and all the paramedics who are present in the OT. So you can have an exogenous source of microbial contamination, you can have an endogenous source. So what are the common endogenous sources, endogenous microbes that may be present, responsible for wound infection?
Gram-negative bacteria.
Gram-negative.
Gram-negative
Okay.
aerobic bacteria.
Gram-negative and I didn't hear you. Come again.
Gram-negative aerobic bacteria.
Gram-negative, like? What is the
Like
commonest we get the report when we send a wound swab?
Like Klebsiella, Pseudomonas,
Yes,
E. coli.
we do. Yes, we do get Klebsiella pneumoniae, but when we get Klebsiella pneumoniae, we are usually a little surprised because they are not the common ones. What are the more common ones? The Staph aureus. We said that the commonest source is the skin. So it is the Staph aureus, the E. coli, the coagulase negative staph. These are the common ones. And if you have done an abdominal surgery, that is when a gram-negative bacillus or an anaerobe which comes in. Okay. So even from the exogenous sources, when again the staph or the strepto, these are the common ones which might come in. So, okay, your patient, you said on day 3, you went in for dressing and you found there was some soakage in the dressing. How would you evaluate your patient? What would you do next?
First, I will clinically assess the patient.
You want to clinically assess? Okay.
Take proper history, do proper clinical
What history are you looking for?
History of fever,
okay.
Vomiting, pain either localized or generalized. Or
okay. Vomiting, why are you looking for the history of vomiting in this case? Fever, I can understand.
Yes, there could be development of peritonitis.
Peritonitis. So you are no longer on the surface. You've delved right to the depth right away. Okay. So see, these are the more advanced histories. If you are a good resident and if you're taking rounds morning and evening, this will never be the first history. What will be the first history that you will get?
Then history of cough.
Cough. Why should, hold on. Why should there be a history of cough? It can, I'm not denying it. But a patient has come, underwent a laparotomy for an acute intestinal obstruction. That's the history we had. And now patient's dressing has a soakage. Okay, so why are you thinking of cough? If you're thinking of cough, what is your thought process?
Chest, there could be the development of chest infection, ma'am.
Okay, so there is a development of a chest infection. Why do you think that will lead to dressing soakage?
No, ma'am, that will not lead to dressing.
Exactly. So yes, secondarily, if you say that she has a hackling cough and then the wound has given way and the intraperitoneal fluid is coming and soaking the dressing, that is a little long drawn process. But I'm saying that the patient is otherwise recovering as per the normal protocol. You have done a first check dressing and the dressing is soaked. So yes. I want to know what other history would you like to take? You had actually told a few questions back. What are the things, clinical features which are characteristic of wound infection? So those are the very histories that you will take. So what are the histories that you will take? What are the histories? Now go back to that and tell me. What are the histories that you will take? Or what are the clinical examinations that you expect in this patient?
Then history of fever.
Okay, pain. You can ask whether the patient has history. Pain, generalized pain, local pain, what sort of pain? Yes, pardon? Is it a local pain you're looking at the incision site or what?
Yes, ma'am. At post of day 3, I will think of localized pain, ma'am.
Okay, what else?
Then I will do clinical examination. There will be tachycardia, check for. I will check for tachycardia, temperature, whether it is raised or not, and look. I will check, see the look of the patient, whether it is toxic look or normal.
Okay. What else?
check the discharge from the wound, whether it is serous, serosanguinous, or pus discharge.
Okay, what else? So if you remember, I told you that divided into 3 headings: local examination, general examination of the patient, and lab findings. 3 exams. Okay. So the first is local examination. Look at the wound. Okay. Is it indurated? Is there any erythema? Is there any swelling or edema? What if there is a discharge? What is the nature of the discharge? And is the patient complaining of tenderness when you're touching the incision site? Local. As far as systemic is concerned, is the patient running a temperature? Does he have any other pain in the surrounding area of the abdomen, not necessarily the incision site? Okay, because you were suspecting peritonitis, as you said. Has there been any wound dehiscence? That is one more thing you have to remember. And when you send the lab, you have to see whether there is a raised count or not, or whether there is a raised CRP or not. So these, you divide it into local findings, generalized overall systemic findings of the patient, and lab findings of the patient. So when you evaluate the patient, don't just think about the wound itself. It must be a very holistic approach. So what investigations would you like to do, or would you at all do any investigations if the patient has a discharge from the wound? You said your patient had discharge of pus from the wound. So would you like to do any investigation?
Yes, ma'am. I will go for complete blood count.
Before that, first thing you've taken off your dressing and you see there is pus.
For culture sensitivity.
Absolutely. So you take a wound swab and send it for culture and sensitivity. Okay. What else? Clinically, when you are taking the wound swab, what else in the wound will you evaluate? Very practical thing. I'm sure you do it as a resident. The moment you see there is pus coming out, you take it in a test tube and you put your hand and check for something. So what do you check for? Don't you check how deep has the wound given way? Is the sheath intact? It's a laparotomy.
Yes.
We often see whether the PDS or the proline, whatever we have used to close the abdomen, has it become loose? What information are we trying to get by looking at all these things?
Whether burst abdomen.
So yes, so whether it is just a very superficial infection at the skin and the subcutaneous level, or is it coming from a deeper plane? So that information will also lead us to think about other things. Okay, so you've sent a wound swab and you wanted to send the blood count. Is there any role of any imaging?
Yes, ma'am. I will go for ultrasound.
Do you go for an ultrasound for all patients?
No, ma'am. If it is if there is pus discharge from the wound, then I will go for ultrasound to
again, I ask you, all patients in the wound who have a pus discharge, do you do an ultrasound for all patients? If you do an ultrasound, what type of information are you looking for?
Collection, pus discharge, collection of pus.
See, your clinical senses are very sensitive, right? So if you think it is just a skin subcutaneous collection, which just by dressing it is drained, then we do not go for a USG. If we will do a USG, only if we feel that there is a deeper collection. Deeper need not be an intraperitoneal. Deeper may be just within the wall at a deeper plane. Which is not amenable to drainage just by opening up 1 or 2 sutures, which we might have to, either do open up more sutures, maybe open it up to lead to a total wound opening up, or which we might need to, if there is a deeper intra-abdominal collection, radiological, we might need radiological assistance to clean it, maybe a pigtail or something. So we do not do an imaging for all patients. If we are suspecting a deeper collection, a collection in the deeper plane, which might require either clinical or operative or radio-guided drainage, then only we do an imaging. And that imaging could, obviously, first line will be a USG, may also be a CT scan if necessary. Right? So all patients, obviously, with a wound infection, you will not do an imaging. Okay, so you are doing dressing in the ward of all these patients with wound infection. So what dressing material do you use, or what solutions do you use for dressing these patients?
Povidone iodine solution, ma'am.
Povidone iodine solution. What is the intent? Why do we use povidone iodine? How does it help in wound infection?
It will get rid of contamination, ma'am.
And then what is the pitfall of using a povidone iodine?
It will hinder in the wound healing, ma'am.
Hinder exactly in which step of wound healing? You're correct, but it's a very broad term that you used. So which step does it actually hinder? It hinders in granulation tissue formation.
Wound granulation, yes.
Okay, so yes, povidone iodine is a good thing right at the beginning when there is pus, but then it ultimately hinders granulation tissue, so it is not a very good idea. So which solution will not hinder granulation tissue? Something very, very commonly available everywhere.
If it is subcutaneous collection, then I will just drain the collection and wash with normal saline.
Absolutely. Normal saline is an extremely safe, easily available, and very, very effective method for doing a dressing. Give a thorough wash with normal saline. It not only mechanically washes away all the slough, it also helps in good granulation tissue. Any role of hydrogen peroxide? If you use hydrogen peroxide, what is the mechanism of action of hydrogen peroxide?
It has oxygen.
Yes. Go ahead. You were correct somewhere. I heard you a little bit.
Then, it has radical.
So it releases nascent oxygen.
Nascent oxygen.
Yes. So how does a nascent oxygen help? So if there is only pus, will you use hydrogen peroxide, or do we use hydrogen peroxide under certain specific conditions?
If wound is heavily contaminated, then
is it the contamination? We are looking at slough, basically. We are looking at slough. Okay, if there is a lot of slough, that is when we use hydrogen peroxide, because the nascent oxygen helps in a chemical debridement of the slough.
Yes.
Okay, so if there is just pus and the underlying tissue is otherwise healthy, we need not use hydrogen peroxide. Yes. If there is a lot of fine slough, then yes, we can use hydrogen peroxide. If there is thick slough, dense slough, then obviously surgical debridement may be necessary. Have you heard of acriflavine solution? Not so commonly available now, but even a few years back, every ward used to have these bottles of yellow solution called acriflavine solutions. Have you heard of it?
Don't know.
Don't know. Fine. See, this is a solution which is an antiseptic solution, but it is additional feature was it's a very good astringent solution. Astringent means it reduces tissue edema. So we said that in wound infection, other than all the features, if you remember, we had said that there is often associated tissue edema. So acriflavine was very effective in reducing tissue edema. But yes, true, it is not so commonly available in any of our wards at all. But if you have a very senior examiner, you might be asked these questions. So I just thought it might be good to bring it up. Now, there's one more situation one more term which we commonly come across, and it is called the necrotizing soft tissue infection. What do you understand by that?
It is the deeper infection involving muscle and the fascia up to the deep layer.
So basically it is a wound infection where there is necrosis of the deeper tissues of the wound. Yes. And the trick is that sometimes the superficial tissues may not be affected. You may only have deeper tissues. So you might be in a false illusion that there is no infection and the deeper tissues might be badly affected. What do you have to do? You must have dealt with necrotizing infection in your ward. What do you have to do then? Up to which layer should you open up if you're suspecting necrotizing infection, soft tissue infection?
It will have dead and devitalized tissue that need debridement.
Yes, it needs extensive, not just debridement, extensive debridement, and You might have to go deeper to the fascia. That
Yes.
is the whole thing. You might have to go deeper to the fascia and do an extensive debridement. And what is the common organism that is involved? The organism is separate from the organisms that we commonly get in superficial wound infection.
Streptococci, ma'am.
You can get streptococci, you can get clostridial infections
Clostridium,
also.
perfect.
Yes, you can get clostridial infections also. Now, any of these wound infections, they might lead to certain complications, right? Any of these wound infections might lead to certain complications. What complications do you get following wound infections?
Ma'am, there will be delay in the wound healing.
Very good.
More
So delayed healing,
hospital
absolutely.
stay.
Prolonged hospital stay,
Prolonged.
leading to further nosocomial complications. Yes, what else?
It will
Orthopedics people are very scared of wound infection because
implant
as a sequel,
due to-
yes, there might be implant rejection. There might be osteomyelitis, right?
Yes.
There might be abscess formation, cellulitis. So again, divided into local complications and systemic complications. So there can be delayed healing or non-healing. There can be other nosocomial infections. There can be abscesses and cellulitis secondary to the infection. There can be osteomyelitis. There can be rejection of implants or mesh. As a surgeon, we are very worried about it. Sometimes we have to take out the mesh following a hernia surgery if there is a bad attack of infection not responding to antibiotics. Any systemic complications that can happen following wound infection?
It can lead to peritonitis, fistula formation.
Okay, what else? When basic things, it can lead to bacteremia.
It can
Yes,
decrease
sir. Yes, sir.
It should start with SARS.
Yes, absolutely. Start with SARS. There can be the bacteremia, there can be septicemia, moving on to SARS and MODS. So do not underestimate a wound infection and think that just draining the pus will be enough. I use two terms, bacteremia, septicemia. How will you differentiate one from the other?
Bacteremia is only increased multiplication of the bacteria without any response, host response.
No, that is the basic difference. Bacteremia means presence of bacteria in blood. But the moment it is replicating, that's when it becomes septicemia. Okay. Septicemia. So you and I, we might have some bacteria in our blood, but that is not causing us much trouble. The moment they start replicating, that is when we start developing septicemia. Okay. Okay. So we've mostly covered most of the things. I'll just ask you a few more very theory-based questions. There are some classification of wounds. Some depending on the contamination of wounds. Can you tell me how to classify wounds depending on the contamination? Extent of contamination.
Clean wound,
yes.
Clean and contaminated wound, contaminated wound, and dirty wound.
Dirty or infected. So what do you understand by a clean wound? And give an example.
Clean wound in which there is no breach of alimentary canal, genitourinary or respiratory tract.
Okay.
In clean wound there is 1 to 3% chance of.
So just give me a very common example from your day-to-day surgical practice.
Yes, like hernias.
Fine.
Surgery.
Hernia surgery. Fine. So that's a clean surgery, a clean wound. Okay. Clean contaminated.
Clean contaminated. There is breach of the alimentary canal there or genitourinary or respiratory tract and
controlled breach.
Control. That description is important. That controlled breach. Okay. It's not that everything is splattered all over the peritoneal cavity. So if it is a controlled breach, can you give one example? From your day-to-day, yes, from like a
cholecystectomy.
Yes.
Okay, a cholecystectomy, a gastrectomy. So this is a control. Appendectomy. There may be some spillage, but most cases there isn't any. So that is called a clean contaminated, and the wound infection is about, it was 1 to 3. This is about 3 to 4%. What about a contaminated wound?
Contaminated wound, there is there is not controlled breach. It is breach.
So there is gross spillage. That was a controlled one. Here there is a gross spillage. Okay. So obviously the wound infection goes much higher up. Like what? Like
biliary.
While doing colostomy, gallbladder has perforated. What happens?
Yes, yes. There is spillage of the contents of the gallbladder.
Gross spillage of bile. You can suck it out, but there is gross spillage.
Yes.
And what about dirty infected?
Clamp, and the clamp has opened up. So there is some
gut fecal spillage.
Yes.
There could be some fecal spillage. So that is a contaminated wound. And what about a dirty infected wound?
There is presence of pus and or could be the fecal contamination.
Not necessarily pus. It could be, dead devitalized tissue. Okay. So that our patient scenario, what we started off with, we said it was acute intestinal obstruction. We went in and we found gangrenous bowel, which you resected and brought out in the form of a stoma. That was our scenario, isn't it? So it was a gangrenous, which is what? Dead devitalized tissue. And usually that gives way and there is fecal contamination. So this is a dirty infected wound. And there the wound infection percentage could be as high as 50%.
40%.
So 40 to 50%. So not surprisingly, this patient after 3 days, our patient from our scenario, who was obese, who was diabetic, who was elderly and had a dirty infected wound, had a wound infection. So you can somewhat predict from the history, the patient factors, the OT related factors, the type of wound, whether a patient is going to have some sort of a wound infection or not.
Yes.
Okay.
Yes.
Sir, shall we stop at this, sir?
Yes, we're almost done. Yes.
You had asked me. Yes.
I can ask a question. You said the wound infection is superficial and deep.
Yes.
And one of the deep infection is necrotizing fasciitis.
Yes.
Necrotizing fasciitis is a life-threatening situation. When you suspect that patient has necrotizing fasciitis, because patient is having a dressing, and there are some parameters to suspect, yes, this patient has got a very fulminant deep space infection. How to suspect?
There will be
patient who are immunosuppressed, patient diabetic, anemic. So this is the background of the patient. And what happens?
Pain. Pain will be more according to the post of day.
Patient has pain which is out of proportion to the surgery being done. They've done an appendectomy and patient is complaining of pain on the whole of abdomen. Okay, maybe in the back also. So the pain out of proportion to the surgery. Then next, this is invasive infection. So
there will be increased temperature. Yes.
Patient may be toxic. Patient may be febrile.
Patient will be toxic, dehydrated.
If you open the dressing, looking at what you can suspect, yes, this patient might have a necrotizing fasciitis.
Yes, sir. Sorry, sir.
What can happen on the surface?
There will be erythema, presence of erythema, and there will be signs of inflammations.
Yes,
there can be blisters. Blisters.
There can be blisters. And if you put your hand, crepitus may not be there, right? Yes, it may be there, but it's not. But the more important thing is induration. You find large area of induration around the main wound.
Yes.
We discussed the other part. Yes. I think we can conclude. Yes. It's a good.
I think I'll just share 2 or 3 slides with you, Onkar and others. Sir had asked me, so I just give me a moment. Yes, can you see the slides?
Yes, yes.
It is just a summary of what we have discussed till now. So I'll just put it in a nutshell. So yes, this was a definition, that is replicating organisms in a wound leading to host tissue injury. These were the characteristics which we have discussed, and if you remember, there were local characteristics and systemic characteristics. Etiology could be patient-related factors and procedure-related factors. The organisms could be endogenous or exogenous. The classification, as Onkar has very correctly said, could be clean, contaminated, contaminated or dirty. There's another classification which we did not touch upon intentionally because I thought I'll put the slides on, is the superficial incisional SSI, deep incisional SSI, and organ space incisional SSI. Now, the superficial incisional SSI accounts for over 50% and involves the epidermis and the dermis mostly, and the subcutaneous tissue. So this is what we so commonly get in most of our patients who suffer wound infection. The deep involves usually the muscles, and the organ space is obviously the deeper level. So by definition, it will be that it occurs within 30 days of the operation and involves only skin and subcutaneous tissue, the other features remaining the same. Again, it is not a superficial incisional SSI is not to be considered if there is a stitch abscess, if there is an infection at an episiotomy, a circumcision site, or a burn wound, or if an SSI extends into a fascia or a muscle. It starts off with the subcutaneous SSI and then goes deeper, then please don't consider it to be a superficial incisional SSI. Deep incisional SSI again has to occur within 30 days. But if there is an implant, it could be a surgical implant like a mesh, or could be an orthopedic implant. This 30 days is extended to 1 year. It usually involves deep soft tissues like fascia and muscle, and rest of the factors remain the same. As far as organ space SSI, again, 30 days of operation to 1 year if an implant is present. This involves anatomic structures which are not opened during the operation. You have done a lap cholecystectomy and you have a pelvic abscess. You have not touched the pelvis. You have not opened it up. But yes, there is a collection there. So that is an organ space SSI. So it includes at least one of the following: a purulent drainage present from a drain. This is what we normally get in ward. There is a drain placed and there is pus coming. Organisms have to be isolated from what the collection is coming out. An abscess in the organ or space is identified either by direct examination that we see, I mean, the pus coming from the drain, or maybe the patient is not improving. We do a re-laparotomy and we find a collection. Or histopathology, that means the tissue that we sent has come back with the report saying that there is evidence of necrotic tissue. Or radiological examination, what Onkar was saying, that we might do a CT and find that there is a collection deep inside. So any of these can help in identification of an organ or space SSI. There are some WHO guidelines on SSI which says that patient must bathe or shower prior to surgery. Surgical antibiotic prophylaxis, about this 120 minutes, I have my reservation. There are places which say 30 to 60 minutes, but WHO says 120 minutes. I think it is best to stick to 1 hour prior to surgery. The antibiotic should be given 1 hour prior to your incision so that the peak concentration is there by the time you put your knife on the skin. Preoperatively, oral antibiotics should be combined with mechanical bowel preparation if you are doing an elective colorectal surgery. Shaving is strongly discouraged. Onkar has already touched upon that. And alcohol-based antiseptic solutions are recommended for surgical site preparation, but this is only after the patient has had a bath. You have scrubbed it well, painted the area with a povidone iodine solution, and the alcohol comes only fourth, not as a substitute for all the previous ones. Surgical hand preparation, no substitute to it. And I think post-pandemic, all of us have become experts at it. Oral and enteral nutrition is very important. pre-op poor nutrition, malnutrition, which could be on extremes. That means either a totally malnourished or an obese patient. Both are amenable to wound infection. So enteral nutrition, oral and enteral nutrition is very important. If the patient is on any immunosuppressive medication, do not stop it. If he's on AKT, let him continue. If he's on steroids for some reason, let him continue it. If he is on ARV for HIV, let him continue it. Give patient oxygen in the immediate post-op period for 2 to 6 hours to reduce the risk of SSI. Now, the last point, I put it in red because I could not relate to it, though the WHO guidelines say it. They say that preoperative antibiotic prophylaxis should not be continued in the presence of a wound drain for the purpose of preventing SSI. This is true in a scenario where you give a single shot of preoperative antibiotic. Now, yes, in our scenario, we all agree that sometimes we are a little apprehensive of just getting over with one shot of antibiotic. But what they want to say is that if you are thinking that, yes, I will only give one shot of antibiotic, do not give 3 or 5 or more just because the patient has a drain. If you are thinking of continuing the antibiotic by virtue as a therapeutic antibiotic and not a prophylactic antibiotic, that's a different scenario. But a prophylactic antibiotic is not to be continued just because a patient has a drain. Evaluation, we've touched upon it. Clinical, history, clinical, wound swab, count and imaging as and when needed. Treatment will be drain the collection, dress the wound, debride when necessary, pack when necessary, antibiotics. Complications could again be local and systemic. That's about all.
Okay. Thank you very much, Dr. Samita. Sorry for joining late.
No
You're
problem,
not
sir.
even very suddenly. Okay.
Thank you, sir. Thank you.
Thank
Thank you, Omkar.
So this is the how a ward round scenario goes. So if you know the basic part of this wound care, you can answer all the questions. Thank you. Thank you, Dr. Chatterjee.
Thank you, sir.
Omkar.
Thank you, Omkar. Thank you.
Omkar is better prepared.
Yes, sir. He was well prepared, sir. Thank you.
Thank you.